Hello everyone. Today we are going to go over some of the basics of EKGs just to hopefully help them make a little bit more sense. They are a little bit difficult to understand, but we're just going to review the basics to help aid your studying efforts. So, before we begin, let's do a little bit of a review over the cardiac system because you'll be hearing a lot of terminology throughout this presentation. So I'd like for you guys to understand what I'm talking about and where I'm coming from. So we have systole and diastole. Okay, this is our top number and our bottom number for blood pressure. However, when we're talking about the electrical activity of the heart, there's a difference between electrical activity versus physical pumping of the heart. Okay, this electrical activity is going to help us with pumping the heart, but just so you understand, when we're talking about atrial systole or atrial depolarization or atrial repolarization or even ventricular diastole, we're not referring to per se the number in blood pressure. We're just really describing what's happening in the ventricles. Are the ventricles squeezing or are the ventricles relaxing? Are the atrials squeezing or are they relaxing? And remember, the sounds that we hear when we're talking about kind of that lub and that dub, that's the valves closing. Okay? So, the electrical activation of muscle cells is what's going to trigger that PQRST segment that we really do have. Okay? So, lots of different things can kind of contribute to that. Specifically, it's going to be our SA node that kind of triggers this whole electrical activity across the heart to kind of help us with pumping. However, certain ions such as sodium, potassium, and calcium can kind of affect the heart. If we have any sort of electrolyte imbalances, this can negatively impact the electrical activity of the heart. So, what do we see when we're looking at an EKG? Well, when we see the P wave, this is our atrial depolarization. Okay, so essentially what's happening during our P wave is that my atria is being depolarized. Okay, so the electrical activity is being sent across the atria. Okay, when the valves between the atria and the ventricles now open to drain blood flow. Okay, so where does the blood go? It goes up from the atria and it drains down into the ventricles. So during our atrial depolarization, essentially that's kind of like our atrial systole. It's squeezing the blood so that the blood can drain down into the ventricles. Okay, remember it goes from the AV valves to our through the AV valves to our ventricles. Okay? The QRS complex, this is our electrical impulse as it spreads through the ventricles. It also helps us indicate ventricle depolarization. So now this electrical activity is going through the ventricles. And actually, our QRS complex, in the grand scheme of things, that's our systole, okay? Because remember, when we're talking in the grand scheme of things, systole is our squeezing. So our heart is squeezing blood like out to the body. So when we hear that lub, this at the electrical level is what's happening. And then when we hear that dub, now we're closing and we're refilling, okay? And then the T wave, this is kind of like our overall reset. So we reset and we repolarize everything and we're getting ready to go again. So the basics of EKGs. The smallest box you will see on an EKG strip represents 0.04 seconds. Now you'll see them grouped into larger boxes of 5 of these very tiny squares, and that indicates 0.2 seconds. So when you have 5 of these pink boxes, that contributes to 1 second. Additionally, we will need 30 of those big pink boxes to equal 6 seconds. Now, in a 6-second strip, this is going to really be what's going to help us to calculate our heart rate, because we count the amount of R waves multiplied by 10. But if you only had a 3-second strip, you would just count the number of R waves, and instead of multiplying it by 10, you multiply it by 20. Okay, but it's best to get a 6-second strip because we really want to see, if there's any odd beats that might be thrown in there. If we're thinking it's possible A-Fib, it's going to be a lot easier to see the variation between R to R intervals, but we'll talk about those. When we are calculating heart rate, you just take the peak of the R wave and you just multiply that by 10 if it is in fact a 6-second strip, okay? Something to keep in note is our QRS complex. Notice how it's 0.04 to 0.12 seconds. So it's probably only going to be taking up maybe 2, maybe 3 of these tiny boxes. But if you see a QRS complex that's taking up like a lot of tiny boxes, that's abnormal. We want it nice, we want it tight. And that's going to help us figure out if this EKG is normal or not. Also, our P to R segment is very, very small. So just kind of keep that in mind as well. But no matter what, our first step in determining what an EKG might be, we always start PQRST. Is there a P wave, a discernible P wave for every QRST complex, okay? You might even see some weird lines going on, but when the body moves, sometimes it's a little bit hard to get an accurate reading on the heart. But what we look at all the QRS complexes and ask ourselves, is there a P for every QRST? Not P every QRS, P every QRST. Okay? I'm just going to go back to that slide really quickly. Additionally, if we're trying to figure out if our EKG is normal, for every PQRST complex, we want a nice even R to R interval. Even if we're looking for a uniform distance, okay? Even if my beats are back to back to back to back to back, if I look at each of my R to R, and it is the same distance, same number of seconds between each R to R interval, means that the underlying rate itself is normal. It just might be going too fast or too slow. Now, when we start seeing from one R to another R, I'm a distance like this, and then all of a sudden I go to this R, and now my next R to R interval is very small. That's an abnormal rhythm. So when we're kind of trying to figure out just baseline, is this normal or not, you look at the PQRST, and my advice, look at your R to R intervals. So, if your patient is on a cardiac floor and they're maybe on telemetry, they'll usually have about 5 leads on. It's always going to be our smoke over fire, clouds over grass, chocolate in the middle. And most floors that require continuous monitoring will have a patient on just a 5-lead EKG. Now, if you suspect something abnormal is going on, like, maybe your patient's blood pressure dropped, or they're complaining of severe crushing chest pain, maybe radiating to the shoulder, we want to get a 12-lead EKG done on these patients. The reason we get a 12-lead EKG is because this lets us know in the now what in the world is happening to our patient. Patients can go for stress tests, they can go for echocardiograms, they can go for a bunch of different diagnostic tests. But if we're trying to figure out what right now is happening, I'm getting a 12-lead EKG. If we suspect a STEMI or a non-STEMI, we get that 12-lead EKG. It's going to tell us in this moment what's happening. The same way that I can look out my window right now and say, it's sunny, okay? I'm not checking my weather app to see what it's going to be like in 25 minutes. And I'm not trying to remember what my dad told me the weather was going to be like earlier today. No, I'm looking out the window and I can tell right now it is sunny, not a cloud in the sky. That's our 12-lead EKG. What right now is happening? And that's in these situations, in these critical situations, we need to know that. So it kind of varies by facility, but usually you'll have maybe about like, I'd say like 5 on the chest. You kind of have wherever you would auscultate, you have like the aortic valve, all of that. So you kind of go across the chest, you go under the breast. And then personally in my facility, when I'm putting these on a patient, we put some on the shoulders, some on the tops of the thighs, and then some on the shins, if you will. But other facilities might have you put them on the ankles, on the wrist, but it will end up being 12 full leads. So, what are some special considerations we need to kind of be thinking of when we're thinking cardiac? So defibrillation, this is done on a patient that has no pulse. Okay. You've assessed them, you've kind of tried to wake them up, you've given them like tap, shout, tap, Mr. Smith, are you okay? Mr. Smith's not responding, maybe do a little sternal rub, trying to wake him up. And he's still not getting, like, waking up, he's not responding. We're going to check for pulse and breathing. If he has none, we know that we need to begin CPR and do some early defibrillation to increase the chances of success. But remember, you can't shock on asystole, because what's happening in defibrillation, my heart is very, very irritated. Okay, it's so irritated to the point where it is no longer giving my body some perfusing beats. Now, these beats might be all over the place, or they might be asystole, but just know that the heart is very, very irritated. And essentially, right now, the heart's given up. Okay, it's way too stressed out. It has thrown in the towel. It is surrendering. It is too stressed out right now. Lots of different things can stress out the heart. Overdoses, even drowning. My heart went a really long time without oxygen. That probably stressed my heart out. So my heart, again, just think it's stressed. What's the purpose of defibrillation? Well, the purpose of defibrillation is to find electrical activity in the heart, so to find the quote-unquote stress in the heart and zap out that stress. So what happens when I get rid of all the electrical activity in the heart? My heart finally has time to say, deep breath in, deep breath out. Okay, I don't have all this stress on me. Let me try to restart. Let me breathe in and breathe out. Let me refocus, and let me try again. Okay, because our bodies are pretty awesome. They're going to try again if they can. And that's usually why, like, our pediatrics, early adults have just better resilience in situations like this. However, keep in mind you must have a rhythm to shock, because what is shock doing? It's pulling electrical activity out. It's taking out the electrical activity. If I'm asystole and I'm a flatline, that means that there's no electrical activity happening. So I need to give them CPR to hopefully, by manually pumping the heart, give them some sort of electrical activity to then shock on. So that's why doing very good CPR is very important, not only to continue to perfuse the body and the brain, but to also really help establish a shockable rhythm, which usually will be hopefully putting them in V-Tach or V-Fib. And then we can kind of shock that so the heart can kind of calm down and it can jumpstart again. Okay. Cardioversion, on the other hand, these patients are still alive, and this is done under conscious sedation. Usually if someone's having an irregular rhythm, not a lethal rhythm, but an irregular rhythm that is making them very symptomatic, they can elect to undergo cardioversion. Usually this is more for our rhythms that are, our patients are very symptomatic, they're short of breath, they have a very bad headache, dizziness, nausea, sweating, and this rhythm's just not going away. Specifically, our increased heart rate is quite symptomatic, and usually this is what we're gonna do cardioversion for. And ICD, on the other hand, this is for patients that hearts need a little bit of help, beating and opening, closing, etc. Someone can be atrially paced, which they'll have a pacer kind of in the atria, letting the atria know when to squeeze, when to, do their thing. Or someone can be ventricularly paced. Maybe there's just an issue with the ventricles opening and closing, so they need a little bit of a reminder, a little bit of a shock to, okay, time for me to open, time for me to go. But sometimes patients will be both if they have quite bad heart issues, they might be AV paced. And you'll see those pacer spikes on your EKG. Okay, usually, at least in my facility, they're these little purple lines, and you can tell kind of where they are and what's happening. Again, AED is used in combination with CPR to help aid in defibrillation. Okay, so lots of stuff we talked about. Let's look at normal sinus rhythm. So, with normal sinus rhythm, we have a nice, discernible, neat P wave, okay? Again, representing atrial depolarization. The electrical activity is moving across the atria. Our QRS complex, this is ventricular depolarization. So what is so important about ventricular depolarization? Well, where do the ventricles send blood to? They help send it out through the aorta and into the body. So after our QRS complex, that QRS complex is that shock of my heart saying, all right, time to go, out the ventricles, into the body. So that's really what's happening there. And that's what helps us perfuse. When we talk about rhythm, this is our heart rate. A good thing if you are in the clinical setting and you notice your patient's heart rate kind of is varying a lot. Maybe they were at 64 and then not even like 5 seconds later, they're at like 97 and then they're 74 and then like 30, they're going all over the place. They probably don't have a nice even rhythm, a nice even R to R ratio. So just keep that in mind. Again, when we're counting the heart rate, we're not gonna count any of our like ectopic beats, like our PBCs, because that's not a perfusing beat. But above all else, there has to be one P wave. There's one P for every QRST. Okay. So let's say my patient was in normal sinus rhythm all day, and then all of a sudden I'm sitting and I'm charting, and I see this on their EKG. Am I gonna like panic? Am I gonna run away? Am I gonna like call for help? I don't know, get someone. Well, what do we think's happening here? They're normal, and then I'm seeing just all this fun stuff happening. That right there is artifact, okay? We'll talk about some other rhythms that look similar to this later on in the presentation, but right now, if we're looking at this, this is just artifact, and this probably means maybe my patient's getting up, or they're moving, or they're changing their gown, or maybe they want to put something more comfortable on, like a sweatshirt and some sweatpants. But just, if you're nervous, just go knock on the door and check on your patient, assess them, say hello. Even if nothing's wrong, you can still ask them, you doing okay? Is there anything I can get you? Anything I can help you with? Okay. One thing I would say about normal sinus rhythm is just because in the morning your patient was in normal sinus rhythm, it's not a guarantee they're going to be in normal sinus rhythm all day. So just because they're on normal sinus rhythm, that doesn't mean take off their monitoring. Continue to monitor these patients because they might start throwing some PACs or PBCs. So just kind of continue to monitor these patients. While the underlying rhythm may be normal sinus rhythm, there can be some abnormalities occurring. So that would be like normal sinus rhythm with bigeminy PBCs or something like that. So what are some variations of normal sinus rhythm? Number one, always assess your patient first. What is sinus tach? Okay, so this again, it's our normal sinus rhythm, but it's just sped up a little bit quickly. So usually their heart rate will range from 100 to 180, but that's really the only thing that's abnormal with sinus tach. We still have PQRST. My R to R interval is the same number of seconds between each R to R wave. It's just happening a lot more fast, and there's lots of different things that could cause this. So just really assess your patient. Sometimes your patient might be just chilling in the bed, and maybe they just got up and went to the bathroom and are sitting back, and they just need some time. But go and check on your patient. Are they symptomatic? How do I feel when I run a really long run. I feel pretty short of breath, pretty dizzy sometimes if I was sprinting or doing some sprints. Might feel anxious, but what do we know is kind of associated with sinus tach? If it's not like because I was working out, well, it's just our fight or flight, our epi and norepi. So for these patients, we assess them and we just look at their heart rate. If this were a 6-second strip, I know it's not, it's a little hard to sometimes find photos, but let's say this was a 6-second strip. So I have 1, 2, 3, 4, 5, 6. So that would be technically 60, but let's say that this was in fact a 3-second strip. Then my heart rate would be, I counted 1, 2, 3, 4, 5, 6. 6 times 20, 120. So this would be sinus tach. So what do? We treat the underlying cause. If my patient's having an anxiety attack, maybe they have some anxiolytics. If my heart rate is just constantly being sustained, maybe it's time to give them a beta blocker. Okay. Maybe they just drank a bunch of coffee, which clearly I need right now. Maybe they just drank a bunch of coffee. Stuff's happening, but it's really important to assess your patient, because we know that sometimes when patients are dehydrated, they can become pretty tachycardic, or early signs of shock can be like a slight tachycardia or just even an increase in heart rate. So assess your patient, try to see what might be going on with them. Okay, I encourage you to kind of poke a little bit, and dig a little bit deeper for these patients. Sinus Brady, on the other hand, this is the same thing but just slow. So if we look at our strip, let's say that was a 3-second strip. 1, 2, 3, 3 times 20 for a 3-second strip, 60. So just kind of keep that in mind. So for this, we would say the heart rate's just a little bit less than 60, because see how like it kind of ends when like in the middle of my T waves. That might not be like a full one, but usually this would be about 60, but don't worry too much about that. Again, everything's regular. You have P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. So what's going on? One little caveat is this is really common in athletes. They usually just have a lower resting heart rate than others. So if you're caring for a marathon runner that's on the USF Go Bulls track and field team or cross country team, maybe their heart rate's just a little bit lower, and that's fine. But that's also why it's very important to get a good history on these patients and assess them. What are some signs and symptoms of a very low heart rate? Well, dizzy, fainting, confusion. If at any point I'm just like, why are we concerned with like a low heart rate if it's not normal for the patient? Is, well, low heart rate, I might have a hard time perfusing. And what am I really concerned about? Perfusion to the head. So the first thing you'll kind of see is some like alterations in mental status. So if at any point my patient, I'm just a little nervous, whether maybe their heart rate's really low or their blood pressure's really low, and even if I'm like in the room with them, I'll be asking them probably every 3 minutes, hey, do you know who you are? Do you know where you are? And they might get tired of you asking that, but I'm trying to look for any sort of clues to help me figure out what in the world might be going on. If I start asking them, like, where are you? And now they're just mumbling to me, and now they're not even talking to me, like, I know that there's something wrong and I probably need some help. So what do? We treat if it's symptomatic. If they have chronic symptomatic bradycardia, this is where our pacers might come in, our ICDs. Okay. For acute situations, atropine can help bump up the heart rate as well, but this is more used in like the acute emergency setting for these patients. What are our nursing considerations for atropine administration? They do tend to dry you up quite a bit. And my patient is going to undergo procedure in which they get an ICD, we provide education, and we obtain consent. So we talked a lot about normal sinus rhythm. Let's talk about some issues with our atria. So again, atria contracts on the P wave. This begins our atrial systole, our atrial squeeze. Where does the atrial squeeze? It squeezes through the chambers into the ventricles. During ventricular dipole, this squeezes blood into the aorta and out to the body. So what would that be? That would be our systole, and that would be our lub. And then once our lub finishes and that squeeze is done, then you hear the dub, which is the closing and refilling. Pretty cool stuff. So A-Fib is probably one of the most common dysrhythmias people tend to have, at least in my experience. But essentially what's happening is my atria has lost its kick, okay? You can also hear as the atria are quivering. So you'll just see some uncoordinated P waves that really we can't discern, if that makes sense. I don't know if what I'm seeing is a P wave or a T wave or just some weird stuff. But how do I know that this is A-Fib? Look at my R to R waves. They are not equidistant between each R to R. My first R to my second R wave is very small. Then my second R wave to my third R wave is very large. Then from my third to my fourth, I'd say it's a little bit medium. And then from my fourth to my fifth, it's also a little bit medium. Okay. So yeah, and if this were a 3-second strip, we do 3, we count 1, 2, 3, 4, 5, 5 times 20, and then we kind of work from there. Okay. 100. Okie doke. So what are some symptoms these patients might have? They might have some hypoxemia, some pallor, tachycardia, palpitations. Usually A-Fib, you'll see A-Fib with RVR, with rapid ventricular rate, meaning my heart rate is very, very high. Okay. Patients with a history of A-Fib might just report an odd, weird feeling. Okay. But if you notice this on the monitor and you see my atria having a little bit of an issue, my atria are kind of going all over the place because that nice squeeze is not coordinated anymore. Maybe they're got or atria. There may be kind of one is like squeezing at a time when the other like shouldn't, instead of a nice even squeeze, if that makes sense. So, what is our major concern with A-Fib? Well, in the atria, what happens when I can't get a nice effective squeeze? Well, if I can't squeeze it all out, it's going to stay in the atrium. What happens when blood stays somewhere? It likes to pool and it likes to clot. And what we're specifically concerned about the atria is that the atria have like these little pockets that sometimes blood likes to sit and stay in. This won't be tested upon, but from my personal experience, lots of patients with chronic A-Fib will undergo a like prophylactic procedure called the Watchman procedure. It doesn't necessarily fix what's going on and causing the A-Fib, but what it does is it kind of fills in that little pouch in the side of the atria so that blood won't get stuck in there and clot in there and possibly get out and get into the body. Okay, so that procedure, you can look it up on your own, but all it does is it helps kind of with preventing clots by physically blocking off the area in which blood would likely clot. Okay, so what can we do to prevent clots? Heparin and warfarin. Remember, heparin works right away. Warfarin does not, okay? So while the patient might go home with warfarin, we need to put them on heparin. Heparin works stat. And always for heparin, we check our APPT. For warfarin, we need to check INR. We need to make sure that it's within the therapeutic range, okay? It does vary per facility protocol, and different colleges and different professors might have like set lab values. So just to review what those are, I know for my facility that I work at, our INR, we usually want between 1 and 3, and our APPT, we want between 50 and 70. But again, it does vary. So just review your normal lab values, okay? And what do we do before administering most of our cardiac meds is we need to check the heart rate. If our patient is on digoxin, watch for signs and symptoms of dig toxicity. And again, our main concern with A-Fib is clots. So just kind of keep that in mind. What might make us think that there might be a blood clot somewhere? What test can we do? D-dimer. D-dimer is a great lab test we can do to see if my patient has clots. A flutter, on the other hand, this is when my P waves, or sorry, my atrial chambers are just beating way too fast, okay? To the point where like the rest of everything, the rest of my ventricles, the rest of all the everything else in my heart can't really keep up. So with a flutter, you'll actually see these sawtooth P waves, okay? Again, my P to R interval, I can't really tell sometimes. And my P rate is also a little bit hard to determine as well, because we're trying to figure out, well, which one was the P wave that worked. I see like some weird waves happening, which might also be like just like early P waves happening. But how do we, when we see this on the monitor and we see these sawtooth P waves, this is our atrial flutter, okay? What do we do if we see this on the monitor? Knock on your patient's door, check in on them, give them a little wave. How are you doing? Are they symptomatic? Are they short of breath? Do they have a low blood pressure? Do they feel very fatigued? So what are we going to do? We're going to give them some cardiac meds, some calcium channel blockers to kind of help relax the heart muscle, beta blockers to help kind of reduce that rapid heart rate, antiarrhythmics such as amiodarone, anticoagulants, and possible cardioversion. One little black box warning on all antiarrhythmics is that they can cause or worsen dysrhythmia, so just keep that in mind. And again, monitor your coags. So now we're going to talk about some issues involving the ventricles, but I believe I do have a slide in here involving the atria, but I'll address it. So what's happening with the ventricles? These are our lower heart chambers. During ventricular systole, we have that squeezing, okay? So through our QRS complex, this is what we would actually call when we're auscultating lub dub, that is our lub, because that's representing systole, okay? Because those ventricles are squeezing that oxygen-rich blood out into the body. So why are we concerned about issues with the ventricles? Well, like I just said, they send oxygen-rich blood out into the body. So what happens if they're not doing that very effectively? I'm probably going to have some low or inadequate perfusion, a very weak, thready pulse. So just keep that in mind. So this one is actually involving the atria, but this is our premature atrial contractions. And I wanted to include this slide right now because we're going to talk about PVCs next. So this helps us compare and contrast what is going on. So again, with our PACs, my atrial tissue is irritated, but unlike A-Fib and A-flutter, it's not necessarily happening before every single QRS complex. It's just kind of, there's a situation in which my atrial tissue becomes irritated, and we have a really hard time finding the P wave because it does happen quite early. As you can see in the photo down below, where I highlighted in yellow, let's go all the way from the beginning, left to right. I have P, Q, R, S, T. I have a nice break. P, Q, R, S, T. P, Q, R, S, T. So I have a really, really quick P wave happening. But then as you can see after, I have a delay. So sometimes these P waves might actually be hiding in the T waves, unlike this photo where we can kind of see where there's a difference. Sometimes you might see PQRST and then all of a sudden a QRS complex without really seeing a nice, neat looking P wave. All that's happening is that my atrial tissues just like kicking things off a little bit quickly. So this then throws off our interval, but as you'll see, it's just kind of occasionally happening where my atrial is just contracting a little bit early. Um, our repolarization phase with like our T wave is so important because we want to make sure that the heart has time to regroup. But before, like, if my heart's still trying to regroup and my atria is like, come on, let's go, let's go, let's go, let's go, kind of a little bit of a problem. Okay, so we really want to monitor the frequency. How frequent is this happening? And if my patient is symptomatic, sometimes they just feel like they skipped a beat, their heart skipped a beat. Most of the time, treatment's not needed. We can do a little bit of lifestyle modifications because we kind of know some of the causes like ETOH, smoking, things like that. But if these patients are symptomatic and they're having an elevated heart rate, we can give them beta blockers. Okay. So, PVCs, what is happening with our PVCs? Well, now, instead of my atria kicking off early, my ventricles are kicking off early, often before my atria are even ready to rock and roll. So what's happening, my ventricular cells are irritated. So when they're mad, they're just, let's go, come on, I'm done, let's go, come on, let's go. So that's really what's happening. So you'll have an early QRST complex before the P wave. So again, if we look down at the photo below, let's go from left to right. P, Q, R, S, T. P, Q, R, S, T. Q, R, S, T. Q, R, S, T. P, Q, R, S, T. But where in the world did those two P waves go? They didn't happen. Why didn't they happen? Because my ventricles were like speeding them up. They were like, we don't have time to wait. We're just going to go right now. And what is the issue with this? Well, they are non-perfusing beats. Why are they non-perfusing beats? Well, my ventricles are beating, but there's nothing in there, if that makes sense. Because my P wave, what happens during my P wave is that the blood drains into the ventricles. But if my blood has never had time to drain from the atria to the ventricles, my ventricles are just pumping, but they're not pumping anything. That's why if you notice your patient is having these PVCs, your pulse rate is going to be different than your heart rate. For example, if you're taking care of a patient in the hospital that's having bigeminy PVCs, meaning every other normal beat there's a PVC, if they are on an EKG, the EKG might read 80 BPMs because it's technically counting these beats because they are beats, they're just non-perfusing beats. But let's say I'm seeing bigeminy every other, and I go down and I feel my patient's radial pulses on their hands, and I count for a full minute straight. I only count 40 beats. Did I make a mistake when counting? Is the EKG wrong? Well, neither. The EKG is right because the EKG counts every beat, but what I felt was perfusing beats. And if they're having bigeminy, that makes sense that I would only feel a peripheral pulse rate of 40 because what I feel is perfusion. Okay. And that's why it's really important to monitor these patients because whenever they're having a PVC, they are not perfusing. Okay. So just kind of keep that in mind. How we really can look straight at an EKG is these PVCs will be wide, they will be bizarre, they will be distorted, they might be too high, they might be flips, they might be, multifocal where they're all going in like different directions, but you'll see widened QRS complexes and they might be really long too. They might like go from the top of the screen all the way down to the bottom of the screen, but these are probably the most easy to identify because they just look wrong. You have 5 seconds to make a decision. This looks weird. Okay. Again, the more PVCs, the more perfusing problems. The more perfusion problems. So we need to treat the underlying cause. What is causing this? Sometimes patients just have a chronic history of PVCs, and that's normal for them. And then we just kind of continue to monitor and take care of them. If they are symptomatic, beta blockers are a really good drug of choice for most of our cardiac problems. But again, we don't count the PVCs when calculating heart rate or pulse rate. So like if I'm teaching my patient like to do their heart rate, is everyone going to go home on an EKG? No, they're not. But if I feel my pulse right now, I get my watch, beat, 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 beat. They're going to be able to monitor the heart rate best that way, because that gives me a picture what's perfusing. Therefore, when I'm assessing my patient, I'm assessing them for some signs and symptoms of inadequate perfusion. Mr. Smith, do you know where you are? Mr. Smith, what day is it? If Mr. Smith is all of a sudden very short of breath and now he's like only aroused to loud stimuli, then I know that there's probably not enough oxygen getting to the brain. And finally, we're going to talk about heart block. So, again, what's happening here in the heart? Well, we talked a lot about our electrical activity. So remember, our P wave is our atria squeezing into the ventricles. After all that blood squeezed into the ventricles, my ventricles are full. So what happens when my ventricles are full? Well, then they squeeze out to the body. So it's kind of in a uniform thing where squeeze and then squeeze, fill, squeeze, squeeze, fill, squeeze, squeeze, fill. But what happens when I squeezed and then my ventricles are full, but then they're waiting a little bit of time? My ventricles are just hanging out, and then they squeeze. That's what we would call heart block, specifically first-degree heart block. So as you can see in the photo down below, what's odd to me about heart block? Well, look, not only do I have like a lower kind of heart rate, but also if we look at it, I have a wide space in between my P wave and my QRST complex. This is not the same as sinus bradycardia. Sinus bradycardia, I have a big pause from the end of my T wave to the start of my P wave. For first degree heart block, we have a big pause in between my P wave and my QRST complex. This is what heart block is. So what do? We assess and see if my patient's symptomatic. Do they feel really tired? Do they have some chest pain? Are they weak? Do they feel dizzy? Are they confused? So what do? We treat the underlying cause. Certain medications can actually cause some heart block. So maybe kind of talking with the provider and pharmacy on what we can do. If we have a severe P to R interval that is like very, very long, we might give them some antiarrhythmics. So that concludes the portion of our Medsurg 1 cardiac EKG interpretation portion of the lecture. Now we are going to go ahead and move on into our critical care portion of our EKG interpretation. Okay? Okay, so again, this is going to be our critical care portion of our presentation. So again, piggybacking off what I said earlier, when we think ventricles, think perfusion. Granted, the atria can contribute to poor perfusion. For example, if maybe the atria aren't draining correctly, then no blood can get to the ventricles. But more commonly, when we see some ventricular dysrhythmias, we're a little bit more concerned about perfusion. Okay, so let's begin with supraventricular tachycardia. So this is different from our sinus tachycardia because now I can get up to 280 beats per minute. Okay, and the complications of this is that really if my heart has to work this hard to produce 280 beats per minute, there's going to be quite a bit of damage to the heart muscle, possible deterioration, poor perfusion. Not only is my body having a hard time perfusing, but my heart's also not going to be able to perfuse to itself. So with supraventricular tachycardia, we really have just rapid PQRST, PQRST. But even so, you can see how this looks significantly different from our sinus tach, where we kind of see that we have like this, our T waves looking a little odd, and we sometimes have a hard time seeing the P wave. So see how we really can't see the P wave too well? Well, this is why supraventricular tachycardia, my ventricles are the ones that are kind of like kicking things off. But again, this is also due to our rapid stimulation of the atrial tissue, and the atrial tissue might really just not be ready to get things moving and grooving. So again, if this becomes sustained, it can severely impact perfusion. These patients will be weak, fatigued, anxious, short of breath, possible syncope. Okay. We're seeing this a lot with, young, healthy people. We also see it a lot with excessive caffeine consumptions, hormone replacement therapy, etc. So, recognizing this is really just kind of a piece of SVT, as we can kind of tell heart rate is 280. So what do we do if my heart rate's 280? Well, what I'm going to do, the first thing that's going to be the quickest onset is our non-pharmacological intervention, such as our vagal maneuvers. So we're going to encourage our patient to do the Valsalva maneuver, that is bearing down like they have to take a poop. If your patient's on a vent, you can suction them. Even just telling your patient cough really, really, really hard, this can help them as well. Carotid massages also can help, but just be cautious with this. It's not used too much in practice, because if you have some atherosclerosis of the carotid arteries, you could possibly, loosen that up, and that's not good. So I would opt for the Valsalva maneuver and some other things, but just be careful, because those movements are intended to drop the heart rate, but we don't want to drop the heart rate too low. Okay. We can also give some of our cardiac meds. If this is very severe and sustained, we can push adenosine. What does adenosine do? It's actually quite a scary drug, because what happens is there's a brief period of asystole, and then the heart will kind of pick itself back up again. But what you need to know about adenosine, resets the heart. After we give adenosine, we need to bolus with saline, because we want to get this, we want to kind of get it in their system, but then kind of flush them a little bit, okay? Cardioversion can also help. That's where they're under conscious sedation, and we're kind of like shocking the heart a little bit. Always have resuscitation equipment and the defibrillator at the bedside. But remember, the ventricle pumps blood to the entire body. If my ventricles are going crazy, this can possibly lead to circulatory collapse. Now, instead of supraventricular tachycardia, we have V-Tach. Think tach, think a just rapid rate. Rapid rate, not a rapid heart rate, and I'll tell you why. So the rate, if we look at our little photo here, count the R's: 1, 2, 3, 4, 5, 6, 7, 8, 9. If this were a 3-second strip, the rate would be 180. Does that mean my patient's heart rate is at 180? No, it does not. Why? What do these look like? These look like PVCs. So what happens when you have a run of PVCs? That is a period of V-Tach, okay? And V-Tach becomes sustained. What do we know about PVCs? No perfusion. If my patient is throwing 12 PVCs, that's a run of V-Tach. What is not happening during that run of V-Tach? Perfusion. So I will not feel a pulse. If this becomes sustained over a long period of time, that means that they have unstable V-Tach, meaning they have no pulse. Sometimes they will have stable V-Tach if they maybe have 1 and then 7 PVCs and then a regular beat and 10 PVCs. You'd still feel a pulse, but it would just be quite weak. But again, if our V-Tach is sustained, it means I don't know when it started and it just keeps on going. Okay, so that is really, really dangerous. This is often the underlying rhythm that puts a patient in either V-Fib or cardiac arrest, and our major complication with an unstable run of V-Tach is death because they are not perfusing. So, what do we do for these patients? If it's stable, they can undergo elective cardioversion. This means that they have a pulse. We can also give them some antidysrhythmics. If it is unstable, what do we do? Well, we always begin CPR, starting with compressions. But before we start that, still check and make sure that they have a pulse. Even if I see a run of V-Tach, I still am kind of up there in the carotids trying to feel if they have a pulse or not, okay? Because we don't want to start doing that if they do have a pulse. But if it is unstable and they in fact do not have a pulse, so we assessed them, they do not have a pulse, we start CPR, starting with compressions, get our AED, and we can kind of push some antidysrhythmics, okay? The rate for CPR, it's always 30 compressions to 2 breaths for adults. And we really want to make sure that we're compressing at a rate of 100 to 120, okay? So as nurses, assess your ABCs, airway, breathing, circulation, and kind of in the middle of all of this, we're going to put them on a 12-lead EKG because we want to see big picture what's happening. We want to see from every sort of angle what is happening, okay? V-Fib, on the other hand, this is just absolute electrical chaos in the ventricles, in which the ventricles are not perfusing, they're not contracting, they're kind of just flopping all over the place. This will have no cardiac output. So what do we know about no cardiac output? That means no pulse. So what do? We assess their pulse, we assess their BP. What are some symptoms of, if someone's dead? Apnea, dilated or fixed pupils, absent heart sounds, cold, mottled skin. So again, even though you see this rhythm, this is a lethal rhythm. But what do we know about lethal rhythms? We can actually shock lethal rhythms with the AED because the AED still recognizes this is a rhythm. It's still going to shock this rhythm, hopefully remove all that electrical chaos so that the heart can take a deep breath in and a deep breath out and then re-pump. Get ready to rock and roll again. So while this is a lethal rhythm, we can shock it, and by shocking it, hopefully we can return them to a normal rhythm. Unlike asystole, there's nothing that the AED can shock. The AED shocks on that waveform. There's no waveform, it can't really shock or do anything. So again, we do our CPR and defibrillation. I also included some info on some advanced cardiac life support drug therapy. If you plan on working in an ICU, they usually require you to be ACLS certified. If you are BLS certified, this just means you can do compressions, you can do ventilations, and you can kind of work the AED, okay? But for ACLS drug therapy, we can give some drugs from like all the different classes. But again, what do? We get a nice 12-lead EKG going. So now we're going to talk about some special rhythms, and you'll see why. This is torsades, not to be confused with artifact. So torsades is usually caused by an antidysrhythmic, specifically amiodarone. What's the black box warning on all antidysrhythmics? That they can cause or worsen dysrhythmias. So torsades is usually a complication of amiodarone. You'll actually see this odd corkscrew helix shape, but it'll kind of be like in the middle of like some normal beats happening, but you'll actually see this corkscrew, how it's kind of big, and then it gets nice and small, and it kind of runs off. That's torsades, okay? Not artifact, where everything's kind of smushed and going all over the place. This, we can actually really see this corkscrew helix. So what do? Mag sulfate. This helps kind of correct the underlying problem, specifically with magnesium. And that just goes back to the pharmacology of amiodarone. So just keep that in mind. Ventricular asystole. This is a ventricular standstill. I have no ventricular rhythm. My atria aren't doing anything and my ventricles aren't doing anything. Usually results from advanced heart failure if hyperkalemia becomes severe acidosis, or just any sort of hypoxia, like drowning, for example. My heart was fine, but maybe I just, like if we had someone that drowned, was the heart the reason the heart stopped? Well, not necessarily. They got a lack of oxygen from breathing. That's why we always prioritize airway breathing circulation, because without breathing, I cannot have a heart function, heart rate, if you will, because the heart needs oxygen to work. So, these patients will have no pulse, no BP, no cardiac output, and no perfusion. So what in the world do we do? Number one, assess your patient first. Just because it says asystole on the monitor does not mean we can go in there and start hounding on their chest. Maybe the leads were off. Go in, assess your patient. Tap, tap, tap. Sternal rub. Check for pulse and breathing. No pulse, no breathing. Let's start CPR and let's start with compressions. It's very important that when we're doing compressions that we're doing them at the proper rate, proper depth, proper rhythm. Firm flat surface if you can. Sometimes there will be backboards available that kind of during CPR you slide a backboard under them to just give it a nice firm flat surface. Some beds can deflate and become CPR beds. But just really making sure that we can get adequate compressions, because we need to perfuse, and hopefully by us giving compressions we're putting them in a lethal rhythm such as V-Tach or V-Fib to where the AED can recognize that rhythm and advise a shock. Okay, what do we do? Call a code blue, get an EKG going. Lots of our complications of CPR include fractures, pneumothorax, hemothorax, fat emboli, etc. So just keep that in mind. After CPR, let's say you've restabilized your patient, you're going to need to kind of communicate what might have happened, what sort of traumatic events happened during CPR, because it is quite a traumatic process. And there's lots of research. Should families be allowed to enter or watch CPR or not? There's lots of research showing that it actually provides a bit more closure to the family, but ultimately if the family is freaking out and they're screaming and they're compromising the patient's safety, it's recommended someone has to leave the room. So that is all I have for you guys. Now it's time to go ahead and practice on your own. Some websites I recommend are EKG Academy and skillstat.com. These are just personally what I used to help. I'm sure there's plenty of other amazing websites, but these just take time and practice. If you're in clinical, you'll see at kind of the mother desk, the central hub of the unit, there will be whoever's on monitoring will be kind of on one computer. So just take a peek and kind of recognize what may be going on, and just see if you can recognize what rhythm that patient might be in. Okay? Thank you guys for watching, and good luck on all of your EKG adventures.